Hello, everyone, and welcome to the BPHASA and the ARC Michigan PC webinar series. Just a reminder to everyone that the videos are shut off for all participants and the microphones are muted and the chat function is disabled. Please use the Q&A function and we will be monitoring that for any questions that you might have. Following today's webinar, you will receive a PDF of the PowerPoint presentation and a link to the recording. There are no CEUs for this webinar series. To find recordings of previous webinars, you can access the help, and to access the help desk, please go to our Person-Centered Planning and Quality Improvement Project webpage at the arcmichigan.org, arcmi.org. And so today we have with us Lyndia, who is the Director of and Manager of the Federal Compliance Section.
Hi, thank you, Heather, and welcome all of our webinar attendees. I appreciate you coming to this webinar, and hopefully you'll find it valuable with the information that is shared. So as Heather mentioned, I manage the federal compliance section. So we are in the Bureau for Adult Home and Community-Based, or I'm sorry, we're in the Division of Adult Home and Community-Based Services. And the Bureau is the Bureau of Specialty Behavioral Health Services. So that was formerly known as what you probably heard as BHDDA. And we had a reorganization, I believe it was like last March. So we went under what is now referred to as BPHASA, which is the Behavioral and Physical Health Services. Oh, I see. Aging Health Services Administration. See, it's the longest acronym in the world. But anyways, under the federal compliance section, what we do is we oversee the 1915C Home and Community-Based Services Habilitation Supports Waiver. We also oversee the 1915I State Plan Amendment, or you'll hear it referred to as 1915I SPA. We also oversee the implementation and monitoring of the HCBS rules. The waiver site review team is housed under federal compliance, as well as self-directed services for adults and person-centered planning policy and initiatives. We do have some new initiatives that have recently come into federal compliance. One is the critical incident report reviews, and that is just really a process. We always reviewed the critical incident reports for our 372. That's the required reporting to CMS. But the electronic visit verification, that is a new initiative. It's a CMS requirement. And so we are at the very beginning stages of that. So just thought I'd mention that in the introduction, an explanation of what federal compliance does. Next slide. You know, I probably should have mentioned regarding the reorganization. In the past, the federal compliance section did oversee the other C waivers, which was the children's waiver and the serious emotional disturbance waiver. That was moved over into the Children's Bureau, but we still do a lot of coordination and work with them, especially when it comes to the required reporting to CMS and also for the site review process. So I'll start. The purpose of this webinar is really just to provide you updates from the federal compliance section perspective. There's a lot of things we have going on. One of them is regarding the 1915 ISPA. So I thought it would be helpful to provide an overview. Many people have, you know, if you don't have a lot of knowledge of the waivers, that's okay. It can be pretty complicated. And so when most people hear about the 1915 ISPA, they think it's like, oh my gosh, this is, you know, this is something brand new, you know, maybe you've heard like not the greatest things about it, but it's just really what we've done is we've sort of moved from one authority to another. So previously, all of these services were housed under what was called our 1915B3 Specialty Behavioral Health Services. And so we had back in 2000, it was probably, we started doing this work, I would say 2017, 2018, when we have our waiver renewals. CMS had required Michigan to move away from the 1915B because we were not able to show the cost effectiveness of it. And, you know, when you look at the services that are provided, you know, through the formerly 1915 B3 services, there's a lot of services. They're highly utilized. And so CMS gave us the directive, like, you can no longer provide these services under the 1915 B3 authority. So we had to find another authority. And that is where the 1915 I State Plan Amendment came in. Again, we explored everything that we could to see what would mirror the B, what would mirror our processes for B services, but we were not able to find anything. And so we followed the guidance of CMS and we transitioned all of our specialty behavioral health services and support. So again, those services under the 1915 B3 to our 1115 behavioral health demonstration waiver. And so it was through the 1915 IHCBS State Plan Amendment, which occurred on October 1st, 2019. So that started fiscal year 20. And the reason we did this is because state plan amendments require an approval from MDHHS. If any of you are familiar with the way the autism services started with the state of Michigan, as they were also a 1915 I State Plan Amendment. So they required approval from the state of Michigan before the individual could start receiving autism services. And that is similar to the 1915 I. And so we recognized, because, you know, our last data poll in terms of individuals who might qualify for these services, we have about 50,000 beneficiaries in the state of Michigan. And so to move that over immediately within a year, we knew it just wasn't possible. So that is the reason we had it sort of embedded into our 1115 behavioral health demonstration waiver, knowing that we would need time for this to be independent. And that's really kind of where we are now. One hiccup was COVID. We really thought we would have this waiver sort of independent and no longer under the 1115 much earlier than it is now. So that ended up causing us to request an extension for to come into compliance with it being independent of the 1115 behavioral health demonstration waiver. So that's kind of where we're at now. So again, going back to the eligibility determination and that approval that has to be under MDHHS, we are transitioning all of those individuals that are currently receiving those services into what we call our waiver support application system. So that is so that MDHHS can provide the final approval of that. On here, I've just provided some information about some of the requirements for the 1915 I. Again, we anticipate those that are currently being enrolled are already receiving the services, and that our PIHPs are doing, you know, they're making sure that the individuals qualify for these services. They're providing all of the documentation and the information in the WSA. MDHHS reviews those and then makes the final approval for eligibility. Some of the requirements from CMS in terms of individuals to receive 1915 I is that they must receive at least one 1915 I SPA service every 3 months, in addition to monthly monitoring. and that, there's still a lot of, despite the communication that's gone out, we're updating the Medicaid provider manual. So there was a bulletin that went out with those updates that included the 1915 ISPA language. There seems to be this idea that we have a paperwork, that there's additional paperwork that's collected from the families they have to complete. And that is not the case. In fact, the process for qualifying for or being determined eligible for the 1915 I services should have been occurring back in FY20. What we've, the difference is we just now have a formal process where the individual eligibility is put through the WSA and MDHHS makes their final approval. So, in terms of what was done before, any assessments, biopsychosocials, the plan of service, those things were always required. And they were always required on an annual basis. So we're not asking for any additional, requirements from the individual served. We're really just asking that it be reviewed, all of these documents be reviewed at that level or at their level, and then, put into the WSA for our final approval. I don't know if we have any questions about 1915I. If not, we can move to the next slide.
I haven't seen any yet, so we will move on.
So another big area that we provide oversight for is the home and community-based services rule, or HCBS. And that has been a very long process. I believe it was back in 2014 when CMS had provided information about this rule and what it would require states to do. We've, in fact, I believe, have had 2 extensions on the time frame to come into compliance. I believe the first one was it 2019, maybe 2020? It was March 17, 2020. And we received an extension, and then we received another extension because of COVID. So the time frame for everyone to come into compliance for HCBS is actually March 17, 2023. I'm going to just kind of go over the overview, and we'll kind of talk through that progression from 2014 to where we are now in the state of Michigan. So again, the final review overview is just really about what is the final rule for individuals or for settings to be home and community based, is basically that individuals and beneficiaries served, that they have the same abilities and freedoms that anybody without disabilities have. I mean, I think that's sort of the easiest way to put it. And that really, if there's any deviation away from this, that it has to be identified in the person-centered plan, and how the conditions are met. So if you think of maybe somebody who maybe they have issues with, maybe they have a diagnosis of Prader-Willi, so their home requires locks to be on their kitchen cabinets or their refrigerators, that would be that deviation from, free access, that freedom of movement, the freedom to get food whenever they want. And that's because they have a medical diagnosis or condition that they need to have what we'll say restriction in place. And so that is where you would want this identified in the person-centered plan. And so that's really just sort of a very abbreviated version of the HCBS rule, because it's a pretty significant rule. There's a lot of components to it, but we have been working toward this. Again, I think we really started digging into this process probably around 2000, I would say 2017, and we've been working on it ever since. The biggest component to this, which many of you are probably aware of, is heightened scrutiny, or HS is the acronym you'll hear related to that. And so Heightened scrutiny is the review process that's required by CMS. So that's related to services or settings that may not be home and community based. And so the purpose of the review process for heightened scrutiny, and again, it's pretty significant, is that is there a way to find out if these services or if these settings can become home and community based? So ideally, there are three, there are two things that we look at for heightened scrutiny. Is the setting isolative? Does it have institutional characteristics? And then also, is it going into the community? Is it integrated? So there's the three prongs that are related to that when we look at heightened scrutiny settings. The institutional, that we don't have ICFs, we don't have those care facilities in the state of Michigan. So we don't really, in terms of institutional characteristics, we don't have those in Michigan. So for settings, to get on heightened scrutiny because of that, we're not going to see that in the state of Michigan. More so what we're looking at is that isolative feature. And that's really what we've seen with the settings that have landed on heightened scrutiny. So where we are with that today is that so from our initial survey process, so we surveyed folks 3 times. Now, if the individuals participated in those settings, participated in the first set of surveys, this information got generated. But there were some situations where we had providers who didn't respond and or individuals didn't respond. So we surveyed 2 more times to try and capture everybody. So in this current status for heightened scrutiny that got submitted to CMS, and we submitted that list in early December, that's from that first, I hate to say the first survey go around process, but really that's what it is. But we did get a large amount of individuals served in settings during that time. So with that heightened scrutiny setting process and that review, where our review process had many facets to it. We had different levels of review, reviewing the site, reviewing documents. We had a committee that reviewed all of the heightened scrutiny review committee that reviewed everything. And we had our internal department review. And we were able to determine that all of the settings that were identified for heightened scrutiny were able to demonstrate and overcome that status. However, when any of those settings that were determined to be in heightened scrutiny, the state does not have the final say. Actually, CMS does. And so that's where all of these settings are right now, is they were submitted to CMS. CMS had a few questions for us, which we responded to. And right now we are waiting for them to provide that sample. So we had over 400 settings that got submitted up to CMS. So of course, they do not have the ability to review every single case that we submitted to them and all of the evidence that we provide to them. So they will take a sample population from that list, and then they will review those settings. So CMS will either make a determination that they agree with the state of Michigan, that we did a thorough review of these cases. Our review has determined that these settings have overcome heightened scrutiny, and they would be in agreement. Or they could say, nah, we don't think you did a good job. And therefore these individuals will have to transition. Now, I know from other states that have gone through this process, many of the time CMS will ask for additional information. So we do anticipate that would likely happen, but we are hopeful that the process that we have taken in the state of Michigan will, that CMS will agree with the process and agree that these settings have overcome their heightened scrutiny status. Now, with that said, I kind of talk about under the current status. I've mentioned the state transition plan and then the corrective action plan. So I want to kind of focus a little bit on the state transition plan, because that does impact heightened scrutiny and then sort of blends into our corrective action plan request that we've submitted to CMS. So our state transition plan for the state of Michigan, we have initial approval. And we have there's been several iterations, kind of back and forth of the state plan changes that have been requested from CMS that we have submitted. So one of the last things that we kind of were waiting on is part of the review process for these settings is that settings not only, so a setting could have a heightened scrutiny status from the surveys, but they also could have a non-compliant status or a compliant status in that survey process. So with that said, our PIHPs and our CMHSPs for those settings that were non-compliant, that just basically meant like they weren't heightened scrutiny, but there were some things they needed to fix and correct. And so our CMHSPs and PIHPs worked very closely with them and, help them get into compliance. And then there's also a validation piece that needed to be done. So before our state transition plan, or you might hear me say STP, gets approved, is that we had to complete all that work. We had to get those settings that were non-compliant into compliance, and then we had to get those, we had to validate. That was a lot of legwork on our PIHPs and CMHSPs, but they were able to do that. We were able to get that done. I believe it was like beginning of July. So we then needed to provide that data and that information to CMS. And so that was the most recent submission to CMS. They did come back with that submission, had a couple of questions. We're actually in the process of resubmitting that again. We just it's going through internal review right now. And we are hopeful with that our state transition plan will get approved. I think the last data, one of the things that the communication we've had from CMS is that they want to get all of these state plans approved, these state transition plans approved before March 17th. And my understanding, I think that they, I think there were, I'm trying to remember the numbers, 20 something. I don't know if it's 24 or 28 states that had an initial approval of their state transition plan. I think that they have approved, it was 24. I think they've approved 12. So there's still 12 that need to be approved by CMS, and Michigan is one of them. So we're hopeful that we will, be approved. But again, there's still some question, there's been some questions going back and forth. But why that's important is in our state transition plan, we had indicated that we would provide, so any settings that could not overcome heightened scrutiny, the individuals in those settings, there would have to be some sort of a transition plan. And with that transition plan, we provided a 6-month time frame. So in order to be able to adhere to that, and knowing that we were still waiting for our state transition plan to get approved, we're still waiting for CMS to take a look at our heightened scrutiny settings and review those. With the March 17th deadline, less than a month, we would not be able to adhere to that 6-month transition plan. So we requested a corrective action plan to CMS, just basically asking for, that 6-month time frame for transition if it's needed. Now, again, we have not heard anything back from CMS, and that might be because, we're waiting for that state transition plan to get approved. I mean, there's many factors that could be involved there. And I would imagine that there's a large volume of states that have also requested a corrective action plan. And I do believe that if you go onto CMS's webpage, they have all of those corrective action plans posted. So the public can review those. So that's the status, the kind of where we're at right now. I know we're getting down to the wire of that March 17th date. We are well aware of that. And again, we're just hoping to hear back soon from CMS. But in terms of our monitoring work, I think it's important to mention that, that survey process will be ongoing. We will be incorporating our monitoring as part of our site review process to ensure compliance of the home and community-based services rule. And then we're updating PIHP contract language. We're also going to start to offer listening sessions with providers and individuals served. So kind of going back to basics when this rule first came out. just to answer any questions. Again, it has been a very, very long process. Having COVID happen in the middle of it has not been helpful by any means. But we're all working through it, and everybody's worked really hard to ensure compliance. So we're close. We are close. I don't know if we have any questions, but if not, we can move to the next slide. I just wanted to provide an update for our site reviews, just to kind of give the audience an idea of where what the site review team does, and how this process works. So we have a site review team of 2 individuals, and they complete all of the site reviews for our C waivers. So again, that includes the children's waiver. So that's the habilitation support waiver, the children's waiver, and the serious emotional disturbance waiver. Now we will be including the 1915 iSpa. That will be included next year for FY24. So it will be a larger sample population that will likely get pulled, maybe not as large, but it'll also be pulling samples from individuals that we've never site reviewed before, unless they were formerly part of one of the C waivers. So, where we're looking at this being new territory for is really those individuals that receive services through have the designation of serious mental illness, or those who are serious emotional disturbance that are not on the C waiver. So we will have a lot of providers that have never been through this process with the state before. So, it will be a new experience for many. The way our site reviews are scheduled, and in the way that we complete our site reviews is we review PIHPs. We review 5 a year. So it ends up that each PIHP will have a site review for every 2 years. So for this year, I listed the PIHPs that have site review scheduled. And so you can imagine, so the 5 this year is Lakeshore Regional Entity, Macomb Community Mental Health, Northern Michigan Regional Entity, Southwest Michigan Behavioral Health, and North Care Network. So it's Region 3, Region 9, Region 2, Region 4, and Region 1. Hopefully I got those regions right. So next year, then the other 5 PIHPs would have a review completed, and that is going to be Region 6. So that's oh my goodness, community mental health. It's the Southeast CMH. Gosh, I forgot their acronym. I apologize, but that's with Livingston, Washtenaw, Lenawee, and Monroe. Then there is going to be Region 10 will be included in that, Mid-State Health Network, which is Region 5, Detroit Wayne, Region 7, and Oakland Community Health Network, which is Region 8. So I think I got the 5 there. If I missed one, somebody let me know. And basically just the information that we get through our site reviews, what they're doing is they're looking at performance measures that we are required to report to CMS in terms of how we're doing with our waivers. And that is reported through what we call our 372 report. So the site review team will go through, they will do desk audits for those performance measures. We also do credentialing audits. And then part of that is also some of the work we have the ARC doing, which I'll speak about in a later slide. So if we're ready to go to the next slide. This leads to my brief, what I was just mentioning with the ARC, but we have several, from the department's perspective, person-centered planning initiatives that we have going on. And, MDHHS is very committed to improving the person-centered planning process in the state of Michigan. And this is through a lot of our work that we're doing with the ARC. And also, we're updating the PCP policy and the guidance, and kind of getting back to some of the work that we do with ARC. The webinar is one example. We recently, the ARC did a needs assessment survey for us. For the state of Michigan to determine, where are we lacking in training, or where are areas that our providers feel like we need to really address some training issues. And that provided us, and that was recently completed, and provided us some really good information in terms of how we should move over. So it helps inform the webinars that the ARC will schedule. So these webinars that this webinar that you're participating in. In addition to that, it helps inform the department of areas that we need to do some trainings on, and that can be completed through some of our conferences that we have, in addition to this monthly webinar. Some other initiatives that the ARC does is, I had mentioned their involvement with the site review. So really helping us from a quality perspective and a quality assurance perspective. So they conduct interviews with our waiver participants. So it's either with individuals served or individuals served and their families. So we're able to get a lot of great information. It not only informs us of if there's any service related issues or service compliance issues, but also how's the network, how's the state of Michigan doing with, informing about self-directed services, or self-directed budget options, or individuals self-directing their services, independent facilitation, even just the person-centered planning process in itself. And if people are, feeling like their goals and objectives and that they're being listened to, and the person-centered plan reflects this. So it's been very helpful. It's definitely an initiative that we plan to continue. I think it'll be really insightful as we move forward with including the 1915 ISPA beneficiaries in this process. And as I stated, we are updating the person-centered planning policy and guidance. We are doing that internally initially, and then we'll introduce our proposed policy and guidance to some of our community partners to get their feedback and individuals served. So I know there's a lot of focus on, one of the things we see we're getting away from is the idea that, it's a process. Person-centered planning is a process. It's not just it's the pre-plan and the plan of service and we're done. Like that's it. You don't have to do anything more. Person-centered planning should occur all the time. And so we're recognizing that the focus is getting primarily on just like meeting the requirements for the pre-plan and the person-centered plan or the individual plan of service. And so this is all of the work that we're doing with these initiatives, is to really get back to that, the process of person-centered planning and how that impacts how is the individual and their family involved in that, and what does that mean? What does that look like for individuals that provide services to our beneficiaries? And so the other thing that we have is we have some work groups that have been going on. We had the first work group, which they did a lot of work, I want to say last year, might have been a little bit longer. And they really worked on the goals and objectives in terms of defining each of them. What are the relationships between the two? The work group did a great job. There's several documents that we have as resources, which define the work that goes into creating well-written goals. Some of the data and information that we were able to get from that, and we are working, the ARC is involved with this, but also we have our partner TBD Solutions that is assisting us with this work. And I just think they've done a great job thus far. Everybody has with this work group. I'm going to say the work group has done a great job. And so we have a larger work group right now that's currently focused. So it's kind of continuing that work, but it's focusing on the learning, planning, convening and implementation and monitoring of that person-centered planning process. So again, trying to get back to the idea that this is a process, not just a plan, not just a document. So that's really a lot where all of these initiatives are focused on and what we're trying to do.
And Lyndia, we did have a couple of questions about where can we access the resources from that first work group?
I believe so. We have we needed to get communications to approve those documents, and I believe we just got approval. So I know the second part to that is we had a web page redesign. Gosh, it was several months ago. And so we have found a lot of the information on our old web pages have sort of disappeared. Like we were not really sure where it's at. So we're working on updating or creating a web page. Again, just a lot of internal discussions going on in terms of how this will work and where the page will land, but we will eventually have that on an MDHHS web page. It might be a little bit of time, but my understanding was that our person-centered planning self-directed services analyst was going to get that out to members of the work group and other folks. I think approval just was recently provided, and I think it's also going out to the current work group that we have. So we are working on getting that out. It just got approved, so we're pretty excited about that.
Okay, great. The only two questions we had were both related to being able to find those resources. So.
Oh, great. Well, I'm excited that people are looking forward to them and want to see them. So that is a great sign. We'll get them out to you. I think we maybe even talked about putting them on the ARC's webpage, but I just don't know if we've gotten to that, gotten that far. Because again, we just got final approval. I believe it was last week.
And we can definitely send out the link when the website is updated.
Okay, perfect. So I just wanted to provide some other updates. Again, we do have a lot going on. Hold on a minute. I just did something silly and I switched my screen. So I had to, so we do have a lot going on. And so I thought it'd be helpful just to provide some other work that we're doing. So because of COVID, if you all recall, we used to have an annual waiver conference. I believe the last one occurred in 2019 in November. It is always held in the middle of November. That is coming back. So we hope to get a lot of participants and a good turnout again for this waiver conference. So we're starting the planning for that again. It'll be back in November 2023. So I'm excited, and I believe it'll be well attended just because it's been a while since we've had that. I mentioned it earlier, but we do work very closely with the Children's Bureau, and you know, they're really growing, and that bureau is expanding. There's a lot of good work that they're doing, and so it's been nice to be able to work with them and have that partner focusing on children's services. The other thing that we're doing is we're incorporating, so I don't know if any of you are familiar with MyCal, or you may hear us refer to customer relations management, a CRM system. We currently have our critical incident reporting system in there. We have there's the crisis and access is through that MyCal initiative. So we're moving that site review process into the system. This will make the process much more efficient. You know, we'll be able to pull data and reports from there. We're really excited about it. I think it'll save time for everybody. So, and also, you know, in terms of the documents that we get to review, we have an old system in place. So everything will be kind of in one area instead of having to go to multiple areas to provide the information. We're also working, the federal compliance section is working very closely with the conflict-free access and planning work group that has been going on for the last year. And that's related to the home and community-based services rule. Federal compliance, there are a lot of areas that we need to ensure that there's that conflict-free access and planning. One of the things I can think of more immediately is regarding 1915I, and that is related to the eligibility assessment. That has to be that that assessment cannot be done by somebody who is authorizing services or providing other services. So, this is something that really reaches in a lot of areas for federal compliance. So it's been nice to be able to work with them and, take a look at what they're doing and what is being proposed. The Medicaid provider manual language, we are updating that. As I said, the bulletin language changes for the 1915I, that went out sometime last year. I think they were finalized in the summer, beginning of the fall. And so we are working on getting that incorporated into the Medicaid provider manual. I think the goal, initially the goal was April, but there's some really significant changes. And I say that because if you recall at the beginning when I was talking about the 1915I replacing our B3 services, we have to change that section because right now that section is referenced as B3. And so we've had to do some moving around. So initially we were hoping April, but the changes are pretty significant. So I think the goal is still April, but it may get pushed back to July. We're kind of waiting and seeing right now. The other thing that we're doing is we're working with our partners and internally and updating the code chart. So we want to make sure that the requirements for all of the HCP HCPC codes match what we have in our waiver language, what we have in our Medicaid provider manual language. And the other thing we're trying to do is really move a lot of those provider requirements into the provider manual and code chart. And you can find that on the, and if you just Google MDHHS reporting requirements, you'll get to the reporting requirements webpage. And you will be able to find that work that's being done with that code chart. The public health emergency unwind work. So as many of you are aware, the public health emergency is ending on May 11th. And so we are working internally to provide language in terms of how we are going to unwind from our waiver perspective services. And if you, many of you who may or may not be aware, each of the waivers had and I just lost my train of but there's different time frames for each of the extensions that were provided for each of the waivers. For example, Appendix K is for the C waivers, and that has like a 6-month sort of unwinding time frame. But for the 1135, which is much of the state plan services and EPSDT services, those extensions end when the public health emergency ends. So that will be where the focus of our language will be on regarding those flexibilities that were offered in the timeframes that those are ending. And then last but not least, our waiver renewals are coming up. Hard to believe it's been 5 years, but it'll be 5 years for FY25. So we just started the very beginning stages of looking at our waiver renewal. So that will be for our C waivers. And we plan to initially get some feedback from, again, our working partners, to find out if there's things that like maybe services that though aren't beneficial in the waiver, or services that maybe need to be in the waiver, or just any changes in general that people think could be helpful in looking at that waiver renewal. I think that's it.
Yes, and I don't see any questions, but maybe, yes, now we have some questions popping in. So please, if anyone else has questions, please use the Q&A tool to ask your questions for Lyndia, and we will try to get those answered. So we have a question that says, with the PHE ending, is it or will there be any changes to telehealth capabilities for some of the services?
Yep, some of the services, because of the way our waivers are written, cannot be provided via telehealth, but many of them are. Many of them have the option that they will be able to be done via telehealth. And that policy, that policy went out for public comment, I believe, in the summer. And we were able to get public comment, provide feedback, and that policy will be effective right when the PHE ends. So that means that, yes, there will be options for people to continue to provide telehealth, the services via telehealth. One of the biggest things that CMS said to us was that, services that can be done. And so let me backtrack a little bit. With telehealth, we have in there services that, like many of the services have to be done via audio visual, like in combination. It can't just like a phone call, because some services right now you can make a phone call, or most of it's audio, and count that as a service. Many of the services we will not be able to provide that audio only option. And that's from CMS guidance. That's from the way our waivers are written right now, in addition to what's best practice. So when we looked at the policy, the telehealth policy, we looked at all of those things. But yes, there will continue to be audiovisual. CMS just was very clear, like that these options need to be per the individual. So per the individual's request, that this is what the individual wants, that there is consent, there's informed consent, and that it does not promote isolation. If these services are provided via telehealth, and that the individual and or their natural sports have the capability to participate via telehealth. So those are just some of the requirements that will be and that have been identified in the policy.
And Lyndia, can you tell us if the telehealth policy is finalized?
I think it's at the very end stages of finalization. I have not seen the official finalization of it, but I think it's really close. I think there was maybe some internal review going on, but I have not seen, I get alerts when policies are updated, and I have not seen that policy come through as being finalized yet.
Okay. And when that is finalized, is that something that we can share with the participants?
Yeah, once that gets finalized, we'll get that out to everybody, and we'll make sure to get that out to all of you and get that on the webpage so that people can see that.
Okay, great. Thank you so much. And we do have another question coming in. Now that the end of the PHE is near, we worry about people who may be stuck in nursing homes who need CMH to assist in transitioning to the community. We always ask this question of Elizabeth Gallagher's group work, who works on the community transition services as well. What can people expect from the CMH in terms of services and supports to get out of an institutionalized setting? And will the BPHASA consider making these expectations consistent across the CMH area?
So we would follow the same, that transition, the community transition policy that you're speaking of. I mean, that applies to all of us. So there's not, it's not an option to not follow that policy. So we would work on that. I think, we do see this as one area. We work very closely with Elizabeth's team for, not only just for the nursing home transitions, but also related to the My Choice waiver, because we do have folks, that may move from the habilitation waiver to the My Choice waiver, or individuals who are receiving 1915I services that, for whatever reason, their circumstances change and they qualify for the My Choice waiver. So we have been working on some updated communication and documents to provide some assistance to the field, but the expectation it is the same across the state for everybody in terms of those transitions. So if you have individuals transitioning out of a nursing home into CMH services, they would follow that transition policy in terms of that process.
Thank you. I don't see any other questions at the moment, but maybe some more will come through. But I do want to remind all of our participants that they will receive a PDF of today's presentation, along with a link to the recording. And our ARC website will be updated this week as well with today's recording of this webinar and with the PDF of today's presentation. And I don't see any other questions coming in. So I will thank you, Lyndia, for your time today. Is there anything else that you would like to share with the group before we end?
Not anything I can think of. I just put in the reporting requirements webpage, so that you're able to share that with everybody. And again, on that webpage, just so that you're all aware, it will have the there's an updated encounter code COVID-19 chart. And then there's also the it's called the Behavioral Health Code Charts and Provider Qualifications. So you'll see that on there too. That COVID-19, that's related to the those services at the time that could be provided via telehealth during the pandemic. So it's going to be a little bit different with the policy.
Okay, thank you very much. And I still don't see any new questions coming in. Are you okay with go ahead and ending the webinar for today?
Sure. Give everybody
Well, thank you
back.
so much, Lyndia, for your time and for your expertise. And thank you for everyone who participated today. And we hope to see you back next month.
Thank you.
Thank you so much.